I think we can all attest that from the discussions that have been happening this morning that primary care is still a key feature in the delivery of health services. But I think it's been recognized since the Alma Ata Declaration over 45 years ago that primary care is essential for the delivery of health for all. This was further reignited with the transition to universal health coverage. But all discussions this morning have highlighted the fact that further investment is still needed in primary care, despite acknowledging that those countries that did really well during the COVID pandemic were those that were able to deliver services and testing at primary care. Maybe I'll start with Dr. Zoka and just ask him to maybe give us some insights on what the US CDC's global health strategy is and how it relates to primary care.
All right, well, thank you very much for inviting me. I think a lot of this comes down to your hashtag, Diagnosis for All, because that's exactly what this is all about. And I'll get to the CDC in 1 second, but I just want to mention that because I'm thinking about this from the standpoint of COVID-19 initially. And what happened here is that, and as one who had to manage this at a state level, is that without testing and without the ability to have a diagnosis, you cannot manage a problem effectively, and that's one of the challenges that we all saw at the beginning of all of this. So I compliment you for all that you're doing and addressing this. The CDC obviously is looking at how do we strengthen systems. I mean, we work closely with all of the different health systems around not only the United States but around the world, and the goal here is to strengthen these health systems, primary health care system, but in general to be able to provide a comprehensive care to all of those who are out there in the community. And without that ability, it is going to be very difficult to improve healthcare around the world. So we work closely with our partners in other countries, but also to help with the national public health labs that we have out there. But what you're talking about a little bit on the primary care front is long before this gets to a national public health lab, you have to be able to provide some of this care in a clinic, or even further back from the clinic in someone's home. And I look at all of the apparatus here, and I realize that this is sort of what we need to do. We need to have this be available to individuals in their homes, in the local health clinic, and to be able to sort of dovetail on the things we've already done, which is like glucose testing and COVID testing, but to make this much more of a multiplex kind of testing where you're able to test for multiple diseases, not just infectious diseases, but other problems that surface. And we work closely, CDC obviously works closely with our partners across the world on that.
Thank you. Maybe before I move on to Dr. Litzia, to focus on something that you mentioned, the partners that you work with in the delivery of testing in countries. If you could expand a bit on how you engage with ministries of health to help strengthen their systems.
Right. So this is sort of at the core of what CDC does globally. We work very closely with the countries, and in the course of the last couple of days, we've had meetings with the ministries of health of many different nations, and obviously the Secretary of Health has met with many of the ministers of health, Ministry of Health in countries around the world. So what we do is we have partnerships. Our expertise can be applied to the communities in the world. So one example is we have a strong field epidemiology training program. So that's not directly with diagnostics, but it sort of is, because if you don't know what's happening, you really can't move forward on that. And so the FETP program has been around for many decades, and there's 21,000 people that have already been trained. It's based on our own epidemic intelligence service program that started in Atlanta many years ago to basically pick up diseases and pick up problems that are out there. So, and then we work closely with the labs that the countries have, and we work with the ministries of what they need. So sometimes it's an issue of lab testing, sometimes it's an issue of help with surveillance. Others is basically helping them build their primary care systems as well. And whether it's workforce issues that come up or diagnostic issues that come up as well.
And I think onto you, Dr. Litzia. I know Lesotho is, just disclosure, I'm from Lesotho. I know Lesotho is working to strengthen its primary care system, looking at the delivery of integrated services at primary care. Maybe if you could just talk us through some of the work that you guys are doing within the ministry to strengthen delivery of services at primary care.
Thank you very much, and thank you, Finn, for inviting us, and thank you, CDC. You are a great partner back at home in a Ministry of Health. And as you have rightly said, I'm the Director General for the Kingdom of Lesotho. Before we talk of what we are doing, we are sadly that country that is still burdened by the HIV and TB, now plus the cancer, particularly the cervical cancer. Hence, number one priority for the government of Lesotho now is strengthening primary health care through integrated approach service delivery, whereby we look at a person not as an individual disease, because we realize that if you look at an individual disease, tomorrow the same person is being diagnosed with a different one and a different one. And this is why the Honorable Minister of Health, who is here in Geneva now, has launched that integrated service provision approach. At primary care, our government, we have an essential service package that is defined and costed, and this service package is delivered not only in government facilities and in private facilities. I must say the health system in Lesotho is like 53% is owned by government, but the other 47% by the Christian Health Association of Lesotho. It's a good partner for us. But as we have rightly said, we are doing all that we can. We provide this integrated approach. We go out through outreach services. Outreach services are such that our healthcare workers, a team of them, they go out to villages to provide services. We do have mobile x-rays that goes with there. We do the testing. We see our priority diseases now is HIV/AIDS, of course it's TB, as I said, and the screening for cancer and providing a treatment on site for precancerous lesions. I must say, as much as we go out to the villages, as much as we provide primary health care at health posts, as much as we provide it at clinics, we provide it in hospitals, regional and the tertiary. Our main experience, even from COVID, is that the testing, the diagnosis is still far from the other package.
Once the tests are available, is there the policy framework to enable testing to be done at community level by the community health workers who are engaging with patients on a daily basis?
Definitely, yes. We have a new policy that was endorsed by the cabinet on the new village health workers, including the new selection criteria and their package of service. So in their new package of service, one of the issues is testing. So they are allowed to do the testing. And I forgot to mention one thing from CDC, that yes, we have the field epidemiology training program, and our first two candidates were supported by CDC. And they're at home now, we are rolling it out. But as you have rightly said, for us, we want decentralized testing. We are number one with TB, for instance. And as much as we have this mobile x-rays, but the gene expert is still far from us. We are still having HIV/AIDS. But our village health workers, until recently, were still not testing. So we're still having a big problem on this sample transporting issues. So we are looking for, one, a decentralized diagnostic services, not only at a short term, but in the long term, coupled with capacity building. Because our village health workers, the new policy is there, but we are now rolling out their training to make sure that even at health posts, as we are beginning to open them up, we are having capacity. We are also hoping to have some of this, what we are seeing here, at that level so that we can enable early diagnosis. And I must say, our experience with COVID in Lesotho it clearly indicated why government has to move this way and has to make sure that the laboratory capacities are strengthened for early diagnosis, because our COVID-19 patients were only diagnosed at hospital level, where they were on the verge of dying, most of them. So this, for us, it indicated to us that these services need to be as close as possible to the people that we have. And we believe that our partners at home and those that we can have even from this gathering can assist us to make sure that we decentralize testing and diagnosis. Thank you.
And I think you bring up a lot of great points here about this, and put a couple notes down. One is you have to have the test, right? So the first part is you need to have the test, right? Then those who have the test have to have the knowledge of how to get the testing done. That's where the partnerships, whether it's CDC or NGOs or whomever is out there to provide the community and to know how to run the test, right? And then you have to get that information to the health providers, because it's going to be done in their home or in the primary care clinic, but then it would have to go to a facility where an intervention, a treatment, what needs to be done next has to move forward.
Yeah, thank you very much. I think for us, with HIV/AIDS, we have moved quite well. We have self-testing. We do provide that. But as I said, there are numerous of diseases and conditions who reach to the hospital very late, yet the testing could have been done at the community level, including just the basic blood sugar and hypertension. We are saying our village health workers, if they should have a glucometer and they have a BP machine, we are just like they do the growth monitoring for the under 5, we really can get to zero of most of the NCDs. Yes, we realize that with the cervical cancer, it's still a bit of a problem. The screening part, because we still need to train midwives, we have a huge gap. But I must say in Lesotho, with the prevalence of 22.7% of HIV, as we all know that most of women with HIV have cervical cancer. And only last year, out of those 610 women who had who had cancer, not only women, we are only 2 million people, but for us to have around 610 new cases of cancers, it's huge. Wow. Out of those 610, 305 were women with cervical cancer. And that is a big problem for us. And of those 305, at least would expect close to 50% of them to die within 1 year because of the delayed diagnosis. We get them at the very terminal stages of their cancer. Hence, we believe HIV/AIDS, the cancers, particularly the cervical cancer among our women, is becoming something of an emergency.
Dr. Zuka, maybe you can talk about what the CDC is doing to help improve access to services for women and girls. I think sexual reproductive health for women in particular is an issue, and there are great gaps in the delivery of services to them, especially because a lot of them in LMICs are unable to access health services quickly due to societal and cultural barriers. Maybe if you can talk about areas that the CDC is working on.
Sure. I mean, this is a huge issue for not just U.S., but everywhere in the world. And we have a strong program to address these issues of women's health. And also, a lot comes down to knowledge and education, and to make sure that we work with our partners around the world to make sure that women and children, and particularly girls, are educated about healthcare issues, so that there isn't a problem there where they're not aware of what they should be focusing on. So that's one part. And then we work closely with the primary, again, it goes back to primary care and some of the clinics to make sure we push this forward, and we work with the partners that are out there who are dealing with women's health issues, whether it's in United Nations or NGOs and other groups as well.
Dr. Lidzie, for addressing the issue of cervical cancer in Lesotho, what interventions are you looking to put in place?
Thank you very much. I think what is key is prevention. we relaunched the HPV vaccination program, I think a year ago, and Her Majesty is our patron. We did very well because we reached 85% coverage of those young girls. And this is now part of the routine immunization. We're doing that, but we are also thinking that, as you know, the proper use of condom, because most of women now have passed that stage of HPV vaccination, and we are promoting condom for proper use, not only to prevent STI, but also to prevent the same cervical cancer. The other thing that we are doing, we have strengthened the health education and promotion and communication. Yes, there have been myths among few parents to say that young girls should not be vaccinated. We are giving them family planning, we are teaching them what. Some were thinking that they will not make children after that. So we are working very hard to make sure that this is understood. And we are now strengthening our screening. We are all over, and we thank FIND, although we still need lots of resources along that extensive screening for cancer. We are hoping to reach more than 200,000 women this year, although we have very limited resources. The integrated approach that we have started, in every gathering, in every site, we are sure we are getting at least one woman. So it is so serious for us. We are getting these women, and what we want to do, we want to get them early, we want to treat them early. So this is what the government is doing. What we are further doing is not only going out as teams, we are also mobilizing resources with our partners and using human resources that is within our partners to do the same. And we have involved the leadership at the community level because we are a kingdom. So us chiefs are very powerful. Whatever we want to achieve, we have to win them first. So we believe that not only, orientating them, there are areas whereby we really need to train the chiefs, particularly their wives, to make sure that the women's health issue, the cultural barriers are finally broken down. Because otherwise in Lesotho, there's an issue of gender-based violence. There's issue of early child marriage. There's issue of teenage pregnancy and early deliveries. So the social determinants of health in Lesotho, we believe that concurrently, as we do the clinical trainings, we need to pull the social and cultural structures concurrently, because they are the ones that can make us succeed.
In a lot of ways, this goes back to this issue of misinformation, right? So you have to have the correct facts out there and provide it to the community. The HPV vaccine that you bring up, I remember when I was at WHO, it was 15 years ago, it just started, the vaccine was rolling out, and there was this whole concern about the safety of the vaccine. And the efforts on the global front was to get that information out there, and then once the information was out that it was safe and effective, then more and more people use it. And now here, we take that for granted that people just getting the vaccine, which is great, but that's not how it began. In the same way, some of these challenges we have today begin with getting the correct information out there to the public.
I totally agree. And I think there's probably a lot we can learn in the delivery of diagnostics at primary care from the programs that have been run for vaccination, where the community is brought into the decision making, into the planning. And that is something that we, as a diagnostics community, are not doing as well as we probably should, especially when we look at, diseases that could be managed at community level, such as various NCDs, diabetes, hypertension. And I think with this resolution on diagnostics that is hopefully going to be adopted, we are looking to one of the things that it calls for is to make sure that countries make diagnostics available and affordable where patients access care. So moving towards patient-centered delivery of diagnostics or people-centered delivery of diagnostic services. Maybe if you could just, Dr. Zuka, maybe say a few comments on what people-centered diagnostics delivery means to you.
So I mean, I think this goes back, I was thinking about this a little bit before the panel began, because way back years ago, it was all about medicines, right? It was all about making sure there was an essential medicines list, that these are the medicines that everyone should have in their community. Pharmacies got them, or if in some communities it was the health clinics that had it, and we said this is what's needed. And my view now is that the diagnostics have become relatively portable, and they've become relatively less expensive than they were. Still, sometimes expensive, but less expensive. And there's the essential diagnostics list. People need to know what it is that you need to have in your community, and whether it's in your home, or in maybe if it's not in your individual, just your personal house, but at least within a small village. Everyone knows they can go 1 block or 100 meters and sort of say, okay, I can get whatever I need to get to test my blood pressure or test my glucose or test whatever. And I feel that it has to become portable and easy to use, and the information has to be out there, and people have to feel that this is important to do. I mean, decades ago, people didn't have blood pressure cuffs at home. I mean, now people just say, well, just take your blood pressure, right? And years ago, we didn't have oximetry at home, and we didn't have glucose testing at home, and it's all coming back to sort of patient-centered care and sort of your ownership of your own health. And I think until we we need to do more of that, and when we do more of that, it will remove some of these barriers that exist and be able to provide care to more people. So.
Dr. Lizzie,
Yes, thank you very much. I was saying I can attest to that. As during COVID, when we were vaccinating the whole community, our own health systems were not getting the numbers. But once we gauged the chiefs, and we were moving village by village, and the chiefs were setting times and dates when we should visit them, our coverage instantly improved, and we are one of the best countries that achieved the COVID-19 vaccination. So we are saying that what we need in Lesotho, we need decentralized diagnostics, because village health workers are already there in each and every village, and the government of Lesotho is now, I'm sure in the next 2 months, they will be in the payroll system. We are one of the few countries that are paying village health workers monthly. By our standard, it's a living allowance. And they take care of 25 to 30 households. So we believe, and if they operate at the health post, which can have the portable diagnostics, because Lesotho, one of the good things about us is that our literacy rate is very high, and almost everybody has a cell phone. So even during COVID, our village health workers were using tablets to report, and they were getting feedback through tablets. So we believe having the portable diagnosis within our health posts that are existing, even before we think of expanding them, because for us a health post is something that is below a clinic, and this can be accessed by each and every individual within 30 minutes, within those 2 to 3 villages. So I think these are some of the things that we are advocating for, because we realize otherwise, if the diagnosis and testing is not timely, we are overwhelmed at tertiary. And at tertiary, it becomes even more complex and expensive to manage these conditions.
If you were to turn to us, CDC in the United States, or Africa CDC, and say there's something that you needed from us or from the CDC, kind of our agency or others, what would that be to help move this forward?
What will that be? It will be decentralize the diagnosis, the testing, to the health post and village level. Let's go beyond, because now our laboratory at hospitals are so nice, but unfortunately very few people reach there. When they reach there, it's a mammoth task. So my humble request, and one single request, will be to decentralize, get the appropriate technology for lower levels, and let's equip village health workers with the testing equipment, glucometers and BP machines, so that we manage this issue on the ground and prevent further progression of these diseases.
And maybe just to add to what Dr. Lydia said, so this means having either battery operated or instruments that do not need electricity, because in those health posts, access to electricity is a challenge. Waste, we should generate minimal waste, because waste disposal is a problem. And also the instructions for the use of the test or conducting the test should be simple and aware, and there should be connectivity in order for the people who are performing the testing at the health post to be able to relay the results.
So I mean, I think that you bring up a great point there about making sure it's easy to use. 2 points. One is the issue of batteries. So this goes back to partnerships, right? This goes back to engineers, public health experts, physicians, community experts to get together and say, this is what we need in our community, and this is how we can move it out. So that's one part. And making it simple. I mean, back to this thing about people taking ownership of their own health. You can go to any airport, you can go anywhere. I keep one at home. These automatic external defibrillators. You ask people, actually literally simple 1, 2, 3, put it on your chest, right, and know how to defibrillate someone. 15 years ago, this was just unheard of to expect somebody to do technology. You just make it easy, make it simple to use. Same with something as simple as an EpiPen, for allergies. People, I strongly believe that everyone has the ability, if they have the health literacy and understand things, to do things, to own their health, and to be able to move it forward. Whether it's defibrillations for hearts, whether it's insulin testing, whether it's shots for epi, whether it's COVID testing. And I think as a result of this pandemic, people realize how much they can own their own health and how they can monitor their health. And you brought up tuberculosis, you brought up other areas, also testing for that as well. And I think it's possible to do, and I think it's a matter of just being aggressive and pushing it forward and not taking no for an answer.
That's very true. And I think the point you raise on health literacy is an important one. Having, how we put the messages out there and encourage people to take ownership of their own health, that will be key. I think maybe we are at time to take questions from the floor.
Hi everyone, this is Rafal Khalifa, and I'm representing the International Pharmaceutical Assistance Federation and the International Pharmaceutical Federation Early Career Pharmacist Group. Thank you so much for the informative session. I would like to inquire, in this primary care service or initiative, how, since the pharmacist is, from evidence, it's the most accessible healthcare professional to the community, so are the pharmacists equipped for from the diagnosis point of view, if we are looking from the problem-solving lens, are the pharmacists equipped well for that, or there is a need for capacity building? And also, because will that help in bridging the gaps of health literacy, accessibility, being closer to the community? So is that navigated, and how the pharmacist can have a better role in that and solve some issues related to this great initiative? Thank you so much.
I'll take a first stab at that and then probably hand over to Dr. Lydia as well to talk about Lesotho. So at FIND, we have programs that we are engaging in with pharmacies, particularly in Southeast Asia, where a lot of people first engage with the health system through their local pharmacy. Particularly through COVID, we engage with pharmacy network chains to train them on the use of COVID tests, looking to make sure that they have quality assured tests available, because that is something else that is of a concern. and then engaging them in making these tests available at affordable prices to communities. So effort is being made. I know effort is also being made through our NCDs program to engage more with pharmacies in the delivery of testing. Also for self-testing for HCV. The pharmacies are being engaged in the delivery of diagnostic services. Dr. Lizzie.
Thank you. In Lesotho, we really engage our pharmacists. But we have two levels. We have the pharmacy technologists. These are the ones that are trained to serve the lower levels, the clinics. Then we have pharmacists. This will find them in the hospitals. But in the integrated approach, we go with our pharmacists because they also set up a pharmacy there and provide. And our kit for village health workers, because we have a standard drug list, a specialized drug list, and what is in the kit for village health workers has been designed and defined by the pharmacists. But we believe with our approach and strengthening primary care, because there's been a lot of misuse of drugs and falsified medicines, we believe we need to get these pharmacies down also, not like the initial plan. They need to be in each and every primary care facility, the pharmacy technologies, so that our nurses do not have to dispense the drugs, so that the drugs are managed well. Thank you.
And make sure that drugs are safe,
Yes.
right? Because that's one of the biggest problems out there, is counterfeit medicines.
Hello, my name's Laura Merrill from Drugs for Neglected Diseases Initiative, and we've heard a lot in some of the other sessions about viability, and we've also heard about affordable prices, and it's interesting to hear your take on people having their own insulin and EpiPens and things like this. But I'm really thinking about, we're talking about UHC, but what about people who just can't afford to purchase these things? So much of healthcare is private already in some countries, and it just pushes households into really big debt. And I'm just wondering, and there isn't really insurance schemes either. And so I'm just wondering how, we're talking a lot about UHC, but is there a whole sort of package that's an economics package that's going alongside this to actually make this possible for people? I mean, you mentioned this Christian organization that was sort of working in Lesotho, and I'm wondering how do they provide this treatments for free or diagnostics for free? It's just about the economics of how to make this work for really, really poor people.
Yes. Okay. In Lesotho, the primary care services are free of charge. Government is paying for that. Government is also paying for those services that are provided under child, including payment of staff for child. So, but we realize as time goes, this takes a huge budget from government, and we may not be able to sustain it, bearing in mind of the emerging and re-emerging diseases. So what the government of Lesotho is doing now is to look at the insurance, how this can be sustained. But even at hospital level, the services are highly subsidized. So what I'm talking about now, the integrated service delivery, whatever, no citizen is paying for that. They go there, they get services, they get treatment, and all that is paid for by the government of Lesotho. Thank you.
I think there's a couple parts to that. One is, government has a critical role in this, but I think this is where it's the bigger question of us as a society and everyone working together on this kind of an issue. And we had this issue back with antiretroviral drugs, right? When HIV medicines were out there and the prices were very high, and what ultimately happened was foundations began, and we know which foundations were out there that pushed really hard to get antiretroviral medicines out to communities where they could not afford the prices of these medications. And I feel in many ways that we are sitting at this situation again with the diagnostics, that others out there have to sort of take this on. And there's a lot of wealth in a lot of different places in the world, and maybe there's somebody out there who just sort of says, I'm going to work with the governments. We'll create a public-private partnership to address this, to be able to move forward and make sure that the diagnostic tests that are costly or get pushed down. And then I think that some of the companies working together could drive the price down for those who can't afford it, so that there's access for everybody for this, just like there was ultimately access for those to get HIV medicines. And that's and then there's what's the public side of it? Well, we have a PEPFAR program, which has been extremely effective and successful to move something forward. So there's the public part of it, and then there's the private part of it to move it forward. And I think that if we want to achieve these successes, we all have to be in this game together. And from the corporate standpoint, I also feel that when you're dealing with health, you do stand on a higher rung on the ladder of corporate social responsibility when you're dealing with some of these issues. And I think that most people in the business world recognize that as well.
Jamila May. I have 3 questions, so please excuse me. But one, is PEPFAR willing to pay for the cervical screening for HIV positive and negative women, or women where their status is unknown? Secondly, do the community healthcare workers at health posts and below, do they administer CRAG tests and TB LAM? And then thirdly, just in terms of your opinion, it seems like the only next innovation we'll have in terms of TB testing is for sample collection, tongue scraping, as opposed to what happens now for sputum collection. Do you see tongue scraping as something that would be beneficial for community healthcare workers to do? Maybe they would consider it safer, or people would be more willing to get tested for TB, including minors coming back from South Africa? Sorry for all the questions. Kalabua.
Thank you very much. Because time was limited, PEPFAR is supporting us so much at home. We have the 3 major cervical treatment centers, and these are supported by PEPFAR, whereby treatment is accessed at those centers. So the whole cost is borne by the PEPFAR through ECPAF. The other thing that you're asking about the village health workers, if they can be able to do that. I said in the new policy, we have looked at this village health worker, and we now have even a village health worker coordinator and a village health worker supervisor. So we believe at that level, because the supervisor is one with a bit of a higher education, is one that is going to supervise these other village health workers, 5 villages, under a health post. So we believe at that level, absolutely, because this coordinator is envisaged to climb the ladder to be eventually a nurse. So we believe what a nurse can do, if the coordinator is capacitated at the health post level, will be able to do that. And at the health post level, is easy to walk to from village to village, and even do some of the procedures at home. So I think I've answered the question.
We just have time for one more question over here, if that's okay.
Hi, Caitlin Ashes from Becton Dickinson. My question is around your thoughts on the role of self-sampling for and particularly for HPV diagnosis in places where you can't have full decentralization of molecular testing. How do you see that playing into the primary healthcare systems?
It does. As I said, we did that with the HIV. But our most serious gap is when the test comes otherwise. When it's positive, now there's a gap of, for the client now, who is there for that client at that time? For him or her to easily accept the test. Because what we saw at HIV/AIDS, everybody was excited to do the self-testing. But now everybody was hoping that is negative. Now when it's positive, we realize a lot of depression, a lot of issues around that. But we believe with the self-test, as we said, a lot of engagement of community health workers with the community counseling, so that you don't really think of a negative test. You also have to cope with the positive test. So we are hoping that these are the innovations that we really want to embark on. Because if you listen to my statistics, for us to do things the normal way, we need to be very aggressive, but at the same time, be very quality compliant and people sensitive. Thank you.
I mean, I guess you mentioned about the cell phones at the beginning, and I almost feel like what would be great is if someone has a positive test, there's some way that they can just click in through their cell phone to a primary healthcare system, or even if it's just a partner, someone to help them through this, so that they now are no longer sitting there with a positive test and nowhere to turn, right?
Yes, you are correct. As we are saying, we have cell phones, but it was so difficult among these HIV clients, because our nurses would actually need to call to say, no, but we gave you a test sometimes. Did you use it? What happened? And you find that the majority of the HIV positive do not even tell the partner, or it's still very difficult. So I think the phone and having this community health workers trained for follow-up and tracking will help us to bridge that.
I think we have reached time, so I'm sorry to cut it off there. Thank you for a great discussion. Thank you all for being a great audience. The questions coming from the floor were quite good. So we can carry on some of the discussions afterwards. Thank you.
Thank you.
Thank you very much indeed. Thank you very much to both of you for all of